Bismillahirrahmanirrahim. Today we are going to start the FCPS 1 recalls question bank of the recent November 2025 from Dr. Wasim FCPS 1 series. The page number is 809. The paper is Medicine November 2025 recalls. The first question is, which of the following is the preferred induction agent for general anesthesia in a patient with acute asthma exacerbation? And the answer to this question is ketamine. Why ketamine? Because it has bronchodilatory effects. It relaxes the bronchial smooth muscles by antagonizing NMDA receptors, and when the NMDA receptors are antagonized, they will cause the increase in the circulatory amount of the catecholamines, and these catecholamines will stimulate beta-2 receptors. Alongside, it also maintains airway reflexes and improves compliance during mechanical ventilation in the obstructive airway disease. So compliance during the mechanical ventilation is also improved, and especially in the obstructive airway disease. The high yield points associated with this question are: ketamine is the bronchodilatory. It is ideal in status asthmaticus or in cases of severe bronchospasm. The agents like thiopental or disflurane can trigger the bronchospasm, so you need to avoid in the conditions like asthma or severe bronchospasm. The etomidate is hemodynamically neutral medicine or drug, but it lacks the pulmonary benefits. The airway reflex preservation with ketamine helps reduce aspiration risk in semi-conscious patient. So this is very important. The second question is, a 30-year-old woman with well-controlled asthma undergoes laparoscopic cholecystectomy. Which of the following is the safest choice for post-operative analgesia to minimize the risk of bronchospasm? So here, the correct option is paracetamol, acetaminophen. Paracetamol is the safest non-opioid analgesic in asthmatic patients. It is because it lacks the histamine-releasing properties and has no effect on COX-1 inhibition in the respiratory tract. In contrast to this, the NSAIDs like ibuprofen and ketorolac can precipitate bronchospasm in susceptible patients, especially those with aspirin-exacerbated respiratory disease. The morphine is an opioid but can cause histamine release, and this histamine release can worsen bronchospasm. The safer alternative in the opioid is fentanyl, and this is prepared if opioid is necessary. The high yield points are: you need to avoid NSAIDs and histamine releasing opioids like morphine in asthma. The fentanyl is prepared if opioid is needed, because it has minimal histamine release as compared to the morphine, which has increased histamine release. The paracetamol is the first line for mild to moderate post-operative pain in the asthmatic patients. You must need to always assess for aspirin exacerbated respiratory disease risk before NSAID use. So what you need to look for? You need to look for the asthma and for the nasal polyps, and especially in association with the aspirin. So if there is asthma or nasal polyps, so you need to avoid the NSAIDs. The third question is, which of the following immune cells is the major scavenger during the inflammatory response? So the major scavenger is basically macrophages. They are derived from the monocytes, and they are the main scavenger in both the acute and chronic inflammation. The high yield points associated with the macrophages are: the first thing is that this is major scavenger in inflammation. The second thing is the tissue-specific macrophages, like in liver, Kupffer cells are macrophages. In brain, microglia are macrophages. In lung, alveolar macrophages are, as evident from the name, macrophages. In bone, osteoclasts are also macrophages. The key associated cytokines with the macrophages are interleukin-1, interleukin-6, and the third one is the tumor necrosis factor alpha. These macrophages can form foreign body giant cells when pathogens or the debris are too long. So this is very important regarding the giant cells which are formed from the macrophages. The fourth question is, chronic inflammation is characterized by which of the following dominant histological features? So basically they are defined by the mononuclear cell infiltration. What are mononuclear cells? So these are lymphocytes, macrophages, monocytes, and plasma cells. They have one nucleus, and that's why they are called mononuclear cells. In contrast to this, neutrophils are dominant in the acute inflammation. The high yield points are: chronic inflammation contain mononuclear cells, that is macrophages, lymphocytes, plasma cells. They lead to fibrosis, angiogenesis, and granuloma formation. The third one is they are common in autoimmune diseases, persistent infections like TB, and foreign body reactions. It involves both pro-inflammatory and repair pathways. The next question is opioid-induced nausea is mediated by stimulation of which structure? And the structure here is chemoreceptor trigger zone, CTZ, which is present in the area prostema. You need to remember that the chemoreceptor trigger zone is chemosensory zone, and this is outside the blood-brain barrier. Since it is outside the blood-brain barrier, so it detects circulating toxins, drugs like opioids in this case, and metabolic disturbances, and then relays signal to the vomiting center to initiate emesis, that is vomiting. You need to remember regarding the opioids that they interact with the mu receptors in the region, which is called chemoreceptor trigger zone, and this trigger nausea and vomiting. And nausea and vomiting in those patients which are, opioid naive patients. The D2, 5-HT3, H1, NK1, and M1 receptors are here. And these are the targets for the drugs to act as antiemetic. The dopamine antagonists, that is metoclopramide, and 5-HT3 antagonist, that is ondansetron, are used to counter opioid-induced nausea. The opioid-naive patients are more likely to experience nausea and vomiting. The next question is, a patient is found to have an obstructed common bile duct on CT scan. Which of the following lab parameters best reflects the diagnosis? The options are indirect bilirubin, AST, ALP, alkaline phosphatase, and direct bilirubin. The correct answer here is direct bilirubin and not the alkaline phosphatase. Why direct bilirubin? Because in extrahepatic cholestasis, that is CBD obstruction, the direct, which is otherwise known as conjugated bilirubin, rises significantly due to impaired excretion of the conjugated bilirubin. This is a key biochemical marker of the obstructive jaundice. Alkaline phosphatase also raises in the CBD obstruction, no doubt, but it's not specific. Why? Because it can also elevate in the bone conditions like Paget disease and metastasis. Okay, the high yield points are the direct bilirubin and the alkaline phosphatase. When both are raised, this is the hallmark of extrahepatic obstruction, or also known as post-hepatic obstruction. Ultrasound is the initial imaging of choice, but CT, MRCP are the better for defining the cause. Dark urine, pale stools, and pruritus are classic clinical clues. The next question is, a phenotypically female presents with primary amenorrhea, normal breast development, sparse pubic axillary hair, undescended testes, and hypoplastic cervix or absent uterus. What is the most likely diagnosis? And the most likely diagnosis in this case is androgen insensitivity syndrome. The complete androgen insensitivity syndrome presents with female external genitalia, absent uterus, undescended testes, and primary amenorrhea, and this is because of the androgen receptor defect. So by karyotyping, the individual is 46XY, but there is defect in the androgen receptor, and that's why the patient is having female external genitalia, alongside the uterus is absent and the testes are undescended. And if there is no uterus, so there will be no primary amenorrhea. The anti-Mullerian hormone secreted by the testes cause Mullerian duct regression. Since the patient is having 46XY karyotyping, so the anti-Mullerian hormone will be secreted by the testes because testes are present, although it is undescended. And this will cause the Mullerian duct regression. So there will be no uterus or fallopian tubes. There will be high testosterone level, but the androgen receptors prevent the virilization and excess testosterone is aromatized to estrogen, and this estrogen leads to normal breast development. So the breast development is because of the excess testosterone, which is aromatized to estrogen. The sparse body hair and a blind ending vaginal pouch are classic clues in such cases. The Mullerian agenesis also causes primary amenorrhea with normal breast development, but pubic and axillary hair is normal and no undescended testes. The 17-alpha hydroxylase deficiency causes sexual infantilism and hypertension, but lacks typical androgen insensitivity syndrome. The 21 hydroxylase deficiency causes virilization, not feminization, as in this case, especially in 46XX individuals. So basically, these are all options which are given to these questions, and we have discussed that why it is androgen insensitivity syndrome and not the Mullerian agenesis, 21 hydroxylase deficiency, or the 17 alpha hydroxylase deficiency. The high yield points associated with these questions are: androgen insensitivity syndrome has karyotyping of 46XY with female external phenotype, absent uterus, and intra-abdominal testes, that is undescended testes. The primary amenorrhea, the breast development, and when there is no pubic hair, so this strongly suggests androgen insensitivity syndrome. The definitive diagnosis of androgen insensitivity syndrome is by karyotyping, hormone levels in which the testosterone will be raised, as so the luteinizing hormone. What is the management of such cases with androgen insensitivity syndrome? So, gonadectomy after puberty. Why the gonads are removed? Because there is a risk of malignancy. And the second thing is estrogen therapy. So basically, you convert the patient to the female phenotype, and you remove the gonads, and you keep the patient on the estrogen therapy in androgen insensitivity syndrome. Basically, the defect in the receptor. This was a little hard, so that's why I spent a lot of time on this question. The next question is: a 58-year-old man presents with crushing chest pain radiating to the left arm. ECG shows 1 mm ST segment elevation in the lead 1 and AVL, along with the reciprocal ST depression in leads 3 and AVF. Which of the following best describes the location of the myocardial infarction? So there is ST elevation of 1 mm in the lead 1 and AVL, and there is a reciprocal ST depression in the leads 3 and AVF. The correct answer is lateral wall MI, because the ST elevation in lead 1 and AVL indicates lateral wall involvement, which is typically supplied by the left circumflex artery or diagonal branch of the left anterior descending artery. The reciprocal ST depression in lead 3 and AVF, which are the inferior leads, supports a lateral wall MI diagnosis due to the electrical vector changes. The reciprocal change adds diagnostic specificity. What will happen in the inferior MI? In inferior MI, there will be ST elevation in the 2, 3 and AVF leads. The anterior wall MI, in anterior wall MI, the ST elevation will be in V1 to V4, while the posterior wall MI usually shows horizontal ST depression in V1 to V3. The high yield points associated with the lateral inferior posterior MI are these which we had already discussed, and that are the ST elevation in which lead, like 1 AVL, V5, V6 in lateral MI, 2, 3 AVF in inferior wall MI, ST depression in V1 to V3 in posterior MI, which is confirmed with posterior leads V7 to V9, and this is important. The reciprocal changes increase specificity for MI and help localize the infarction, as in our case, the reciprocal ST depression in leads 3 and AVF. The next question is: nitroglycerin relieves inguinal chest pain primarily via which of the following mechanism? So basically, the nitroglycerin dilates the venous capacitance of the vessels. The nitroglycerin is converted to the nitric oxide, which activate guanylyl cyclase, and this guanylyl cyclase increasing cyclic GMP and leads to the vascular smooth muscle relaxation. It primarily causes venodilation, which reduces preload by pulling blood in the venous system. So basically the capacity of the vessels is increased. This leads to reduced myocardial wall stress, and if the myocardial wall stress is reduced, so oxygen demand of the heart is also reduced, and hence the inguinal pain is relieved. You need to remember that nitrates also cause coronary artery dilation, and this effect is limited in obstructive coronary artery disease. Why? Because the stenotic arteries are already maximally dilated. When the artery is stenosed, this is maximally dilated. Thus, venodilation is the primary mechanism of anginal relief. The associated high yield points are the nitrates decrease the preload greater than the afterloads via venodilation, and that reduce myocardial oxygen demand. This is useful in stable angina, vasospastic angina, and acute coronary syndrome. You need to remember that PDE5 inhibitors must be avoided. What are PDE5 inhibitors? That is sildenafil, and this is because of the risk of severe hypotension. That is, if you give PDE5 inhibitors alongside the nitrates, so there is a risk of severe hypotension. So you need to avoid both these together. The next question is, in a patient with PCOS and signs of hyperandrogenism, that is acne, hirsutism, which of the following hormone treatments reduces testosterone level? So in PCOS, polycystic ovarian syndrome, which hormonal treatment reduces the testosterone levels? And the answer is estrogen. This is because the combined oral contraceptive, which include estrogen and progestin, are the first line therapy in women with PCOS who are not trying to conceive. Estrogen increases sex hormone binding globulin, and where this sex hormone binding globulin is increased, this is in the liver. So when these are increased in the liver, they bind free testosterone, thereby reducing its bioavailability and lowering androgenic symptoms. This is the primary mechanism by which estrogen reduces serum free testosterone levels. Progesterone may support menstrual regularity, but alone does not significantly reduce testosterone level unless used in combination with estrogen. The high yield points are: combined oral contraceptives are first line for managing hirsutism and acne in PCOS. The estrogen increases the sex hormone binding globulin, which is made by the liver, and they will bind the testosterone, so the free testosterone will be decreased, and if the free testosterone is decreased, then there will be the less androgenic symptoms. If the combined oral contraceptive fail after 6 months, then we need to add anti-androgens like spironolactone. You need to remember the metformin improves insulin resistance and may modestly lower androgen levels as well. And metformin is also the treatment in the patient of PCOS, because in PCOS there is increased insulin resistance, and this metformin improves the insulin resistance. The next question is, a patient underwent bilateral adrenal surgery, that is cutting the adrenals, adrenalectomy, for refractory Cushing disease. Months later, she presents with headache, bitemporal hemianopia, and hyperpigmentation. What is the most likely diagnosis? The most likely diagnosis is Nelson syndrome. What is Nelson syndrome? The Nelson syndrome is a well-documented complication after bilateral adrenalectomy, especially in patients with previously undiagnosed ACTH-secreting pituitary adenoma. So when there is loss of cortisol feedback to the increased CRH, this will stimulate pituitary tumor growth, causing increase in ACTH and MSH, leading to hyperpigmentation because of the increase in MSH, and mass effect, which is because of the tumor, that is the visual field defects in this patient by temporal hemianopia. The high yield points associated with this question is the Nelson syndrome occurs if bilateral adrenalectomy is done in a patient with undiagnosed pituitary adenoma. So the tumor show aggression. There is increased ACTH and so increase MSH and diffuse hyperpigmentation because of the MSH. The diagnosis is done via elevated ACTH and MRI, which will show the pituitary adenoma. What is the treatment option? Treat with transsphenoidal surgery and radiation. The next question is, a 58 years old male presents with chest pain during exertion. ECG shows 1 millimeter ST depression in lead 1 and AVL with reciprocal ST depression in lead 3 and AVF. What is the most appropriate classification? So there are ST depression in lead 1 and AVL as well as the reciprocal ST depression in the lead 3 and AVF. This is basically the NSTEMI, non-ST elevation MI. The ST depression on ECG in symptomatic patient without ST elevation strongly suggests the non-ST elevation acute coronary syndrome, which includes NSTEMI and unstable angina. The distinction between them, that is the NSTEMI and unstable angina, is based on troponin levels. In NSTEMI, there is subendocardial infarction with positive troponins. The reciprocal changes, that is ST depression in inferior lead, supports the lateral wall ischemia, as we already discussed in the previous question where there was ST elevation. But here is the infarction in the subendocardium. So that's why there is ST depression in the lead 1 AVL and there is no transmural infarction. If there was transmural infarction, there would be ST elevation MI, and this is important. For localization, you need to remember ST depression in the lead 1 AVL and then followed by the reciprocal ST depression in the lead 3 AVF, which localize it into the lateral wall. And again, there is no ST elevation, but the symptoms of the ACS, this is non-ST elevation MI, and the second option is unstable angina. And in order to differentiate between the unstable angina and ST elevation MI, we do TROPS. If TROP is elevated, then this is non-ST elevation MI. If not, then unstable angina. The high yield points are ST depression and T-wave inversion plus increased troponins in ST elevation MI. In unstable angina, same ECG changes, but TROPS will be normal. If there is no ST elevation, that means that this is not ST elevation MI. The non-ST elevation MI involves subendocardial infarction and not the full thickness infarction, which is called transmural infarction. The next question is, when should cardiac rehabilitation typically be initiated following a myocardial infarction? So this is before discharge from hospital. The cardiac rehabilitation should begin during the inpatient phase, ideally before hospital discharge, and this will be with low level physical activity, that is ambulation, stair climbing, education, and risk factor modification. This early phase is known as phase 1 of cardiac rehabilitation. It improves functional capacity, reduces hospital readmissions, and enhances long-term outcomes. The more intensive rehabilitations, that is phase 2 and phase 3, can be done after the discharge, especially within 1 to 2 weeks. The next question is, which of the following is a component of the innate immune system? The options are T cells, B cells, natural killer cells, and plasma cells. The answer is natural killer cells. Natural killer cells are basically innate lymphoid cells that respond rapidly to virus, infected or tumor cells without prior sensitization. They are part of the innate immune system, unlike T and B lymphocytes, which belong to the adaptive immune system. The natural killer cells detect cell lacking MHC1, which is a common feature in virus infected or transformed, that is tumor cell. They kill by releasing perforin and granzyme inducing apoptosis. So basically the natural killer cells release perforin and granzyme and they will induce apoptosis. The high yield points are component of innate immunity include natural killer cells, neutrophils, macrophages, dendritic cells. These are the cells of the innate immunity. In humoral component, the complement system, interferons, acute phase proteins. These are the innate immunity in term of the component of humoral, that is humoral component. The natural killer cells have CD16 and CD56 markers which mediate ADCC via IgG Fc recognition. The complement proteins, that is C3, C5, play key roles in opsonization, chemotaxis, and lysis via they make C5b and 2C9. The next question is, a patient presents with difficulty in hand grip but thumb movement are intact. Which nerve is most likely involved? The nerve involved is median nerve. Median nerve injury leads to impaired flexion of the thumb, index and middle finger, which contributes to weak grip strength. However, if the recurrent branch of the median nerve is spared or the injury is incomplete, thumb abduction and opposition, which is a function of the thenar muscle, can remain intact. The key point here is the hand grip is primarily mediated by the flexor digitorum superficialis and profundus. So flexor digitorum superficialis and flexor digitorum profundus is mostly innervated by the median nerve, that is the radial half. Thumb movements, especially abduction, opposition, are also median dependent, but if preserved, suggest partial median nerve injury, likely distal or affecting anterior interosseous branch. The high yield points. Median nerve is the main nerve for hand grip plus thenar function. Hand up benediction, in which the median nerve injury when making a fist, flexion deficit in digits 1 to 3, thumb, index, middle finger. The thenar wasting occurs that will cause F hand, and this is a lead sign. The median nerves also carries sensation from the lateral 3.5 fingers on the former side. So we have discussed till the page 814, and the next inshallah we will discuss in other video.